Good to go, Nicole.
Thanks. Hi, everybody. Thanks for joining us on an odd Friday afternoon. We don't normally do our events on Friday afternoons, but just a lot of events going on right now. So here we are on Friday afternoon. Welcome to one of the two April Flex virtual knowledge groups. This one is about the impact of increased telehealth use on quality, finance, and value-based care. Andy, you want to go to the next slide? Before we really kick into that, Andy's going to put up a couple of polling questions to just gather some information about how you guys feel about your knowledge before we present our content. So while you guys answer those couple of questions, I am going to just give some updates about upcoming events. So Monday, April 19th, the Flex monitoring team is having a webinar about COVID-19 response in critical access hospitals at 2 p.m. Central Time. April 26th, we have a telehealth policy webinar. That'll be the Center for Connected Health Policy and a few others joining us to talk about that. You should see an email soon about that. That is also 2 p.m. Central Time. We have, like I said, this was the first VKG of April. The second VKG of April will be Compass and Critical Access Hospital Financial Indicator Report. So that'll be Friday, April 30th at 1 p.m. Central Time. And then a couple of other reminders. The Flex virtual reverse site visit for this year, or RSV, is January 20th, 21st, and 22nd, virtually again. Those dates should be held on your calendar, I think. Andy, have you sent something out about that?
We haven't sent a placeholder, but keep those held, and then we'll be sending more information soon about registration, that kind of stuff, and how to access the content.
Sounds good. Thanks, Andy. And then our last announcement is on another upcoming learning collaborative about virtual facilitation skills. So if you didn't go through the first round of that and you are still interested in that, reach out to Andy about that by the 21st of May, which is next week. So that is it for announcements. I'm going to go ahead and introduce our speakers. So we have Lindsay Corcoran and Carla Brock-Wilbur of Stroudwater here to talk to us. And I'll just read their bios quick and then let them launch into their presentation. So Lindsay is a compassionate healthcare leader and strong advocate for sustainability and access in rural healthcare. She has assisted rural and community hospitals and clinics across the country to improve operational and financial performance. Her experience as a healthcare administrator gives her a unique perspective on practice operations, customer service, and patient-centered care. Carla Brock-Wilbur is an accomplished nurse administrator with an excellent background in critical care, education, and emergency services. Carla came to Stroudwater from Wake Forest Baptist Health Lexington Medical Center, where she was Director of Enterprise Excellence. In this capacity, she led, facilitated, and supported the Lean Transformation Initiative across the continuum of care and health systems, and was responsible for the development, implementation, and ongoing assessment of comprehensive performance improvement and lean redesign initiatives within the healthcare facility. So with that, Andy, you can stop sharing our slides, and Lindsay and Carla will start sharing theirs.
Okay, are we all set?
Good. Yep, you're all set. Go ahead.
Okay. So thanks everyone for joining today on this call. And we're going to look at telehealth as it relates to the impact on quality, finance, and value-based care. Let's see if I can move my slides. I'm going to just skip over this. This is funded through a HRSA grant. And just a little bit, a high-level overview of today's agenda. There's some learning objectives that we want to touch base with. Look at telehealth modalities and benefits. Some market factors that are either, we look at them as more of disruptors for our rural hospitals and clinics, and some telehealth impacts, as well as having some discussion at the end. So for our learning objectives, today we really want to touch upon some of the market concerns and impacts for rural hospitals and clinics, and some of those market competitors in that telehealth space. And then look at the impact of finance quality for our rural hospitals and clinics, really recognizing the utilization of telehealth to enhance access for our rural health hospitals and clinics. And then also exploring the benefits of telehealth in value-based payment models. And then we'll have some sharing from one or maybe a couple of your peers and their experience with telehealth within their state. And so Carla's going to talk a little bit about the telehealth modalities and benefits.
Thanks, Lindsay. So we usually start with, we need to understand the different modalities, and you all have probably heard this information before, but synchronous, which is what we're all very much more familiar with, is where, and you may have used it, especially during COVID. I have twice, and my husband has once, where we've had our face-to-face through telehealth with our providers. Asynchronous is the store and forward, so information that might be obtained and then forwarded to another location and used. mHealth, remote patient monitoring, and then remote communication technology-based services all kind of get intermingled in one way or another. The remote patient monitoring can go from consumer-facing wearables all the way to ICUs. So, and then the remote communication technology-based services we've seen a great deal of are chronic care management, transitional care management, and then principal care management are good examples of that. Next slide. So telehealth and telemedicine for years were kind of both thought of as the same thing. But really there is a difference between the two. And the major difference is that telehealth is broader. Telemedicine is specifically around clinical services, so remote clinical services, where telehealth can refer to a lot of different remote healthcare services. So just to keep those two kind of separate. For years, we just used them interchangeably, and now it's a little bit more specific and thought of as different. Next slide. So the general benefits of telehealth and telemedicine for all of us, of course, in rural, and we want our hospitals to understand how important it is that they really start to entertain, if they're not using telehealth, entertain the possibility of using telehealth services to improve access, for one, allowing services to be added to the clinic that otherwise would not be there. Providing ED consults. Many of our hospitals benefit greatly from having neuro, cardiac, and psych consults within their ED. And then, of course, expanding new practices that you may not have otherwise that are, we can't really fund and support a full-time person, but by using telehealth and telemedicine modalities that we're able to. There's a cost savings. There have been studies that show that it reduces readmissions. So if our patients can get followed up through telehealth, then maybe we can catch something before it gets really bad, and then they're readmitted to our facility, reducing transportation costs and issues. A lot of our rural communities have transportation problems. So that's a really good place to try to sink your teeth in and say, what are we going to do about that? What can we do by using telehealth and telemedicine? Reducing ER visits. There are facilities who have ER triage through telemedicine where you realize this patient may not need to come to the ER. And so that they're using that to try to reduce really avoidable ER visits. and then just improving efficiency overall. Patient adherence has been known to be a improved outcome. Reduction in no-show rates for patients that just need to be followed up on, and then maybe can't get to the clinic, so they no-show. And then early detection of illnesses or potential exacerbations helps to improve the outcomes. Next. And Lindsay, I think you're taking market. Yep.
Yeah. So really we wanted to also look at some of the market factors that are in play. And we want to update you. I'm sure, you know, it's very relevant. This is the most updated number as it relates to rural hospital closures, but I think this hits home for a lot of states, because as we talk about the increase in competition for patients has a huge impact on the ability for rural hospitals and clinics to continue services and to remain viable within their communities. So we stress the importance of looking at telehealth as an option to expand your kind of the clinic and hospital's reach to obtain some of that lost market share or patients that may be impacted by some market factors. You know, all throughout in the news, we're hearing about, you know, Amazon Care expanding their reach, and other entities and organizations such as CVS and their Health Hub, where they are in response to the pandemic, have really started to infiltrate into the market. Amazon has expanded to non-Amazon employees. And they're offering not just telehealth services and remote services, but they're also starting to offer primary care services, urgent care services, you know, flu vaccinations, any type of vaccinations and testings and lab work. So really it's the bread and butter services that our hospitals and clinics are offering in rural. So this is direct competition for our rural organizations, and should be watched as they come in potentially to your market. And some of the other market factors are around, you know, regulations. We know that the reimbursement and the regulatory changes that have occurred because of the public health emergency. But what is that going to look like once that public health emergency is lifted? Are we, you know, so preparing for that and understanding and watching what those changes and how those changes are going to impact our organization. And then the market factor around infrastructure. We know that a lot of, you know, it's called the digital divide, where there is limited broadband access. You know, 22% of rural population versus the 1.5 urban population lack access to broadband infrastructure. There's challenges around electricity and Wi-Fi access. Are the rural population having access to specific technology to leverage telehealth? You know, we can set up telehealth in our hospitals, but if our patient population does not have access to computers or smartphones, then you know, what good is that? So we certainly have those factors playing. And then our again, about our patient population in rural communities, most affected by this digital divide are women, the elderly, people of color, low tech literacy. So, you know, again, there's this whole aspect of having to educate our patient population on how to use and access this technology if we are to implement it at our organizations. So, you know, these few things are really at the forefront of kind of for hospitals and clinics to have to look at to kind of understand whether or not they want to look at implementing telehealth.
So telehealth impact on quality, finance, and value-based care. Next slide, Lindsay. Thank you. So for quality, I had already mentioned access, specialty providers, being available for consults for much needed care. We hear a great deal about missing work, missing school. It's very costly for a lot of our community members within our rural communities to miss their work. Timeliness in of care, weather conflicts are really important as well. And they would receive more prompt monitoring and communication. Remote patient monitoring, of course, for chronic disease. And I'm seeing a lot around behavioral health. One of the neatest applications that I saw that was being used is an app that was on a person's phone that is in recovery. And they had, as part of their recovery and their peer coach, they had this app has, they had loaded their triggers, the places that really set them off and where they're really trying to get through this substance use disorder and recovery. And in this situation, this patient, anytime they travel near one of the triggers, the phone goes off, connects them with their peer coach. I thought that was really impressive. And then continuing education. I mean, we've done so much over the last, now a little over a year on Zooms, and being able to use different telehealth and telemedicine modalities for continuing education for some of our healthcare professionals saves a lot of time, money, and access to those educational benefits that they otherwise may not have. Next slide. So I have looked high and low and have now for some time. Speaking to what Lindsay mentioned regarding Amazon and some of the disruptors, MedPAC did come out with a statement as and MedPAC doesn't make the rules, they make some suggestions, but regarding the use of telehealth and not ending it right, at the end of the public health emergency, but let's continue to use telehealth, but let's start measuring some quality. Because we need to know, is this, is it quality? Does it provide good quality outcomes and so forth? So the National Quality Forum, and this was back in 2017, developed along with the group several different domains and subdomains of quality measurement. Other organizations have taken it a couple of steps further, but access to care, the financial impact and cost, experience being the experience with the use of telehealth or telemedicine, and then all of the different effectiveness measures where you get into specific clinical effectiveness and system effectiveness and so on. So this is basically the framework that many people are using to start measuring some of the quality of telehealth services. Next slide. So there was an article, Hollander and Neinstein, that mentioned, we should use telehealth to help improve our overall care rather than just driving more use of telehealth as an end to itself. One of the organizations was mentioned in this article, Jefferson Health, had monitored and had taken those metrics from the National Quality Forum and developed some of their own more specific quality metrics to measure their telehealth quality. They saw a decrease in the time between a request and new patient appointments from 18 days for inpatient appointments versus 9 days by using telehealth. The no-shows and same-day cancellations were reduced as well. And then another mention of an on-demand employee health program showed that waiving the ED and urgent care copays increased telemedicine utilization and reduced inappropriate and unnecessary emergency department utilization. I have also seen that in some of these cases where there were occupational injuries, by having a program to use telehealth services has also reduced the emergency department visits and has proven to start treating the patient earlier, and then they don't end up with these huge workers' compensation issues. Next slide.
And looking at the impact of telehealth in the finance realm, when we implement telehealth, we open up some doors for additional revenue streams for the organization. Obviously, telehealth comes at a cost. There's the cost for the equipment, there's the cost for the internet connection or the broadband access. But it also, expands our reimbursable services. And with all the changes that are happening for reimbursement for telehealth, this is a additional revenue stream for an organization to capture. When we look at market share, as I mentioned before, is that, telehealth helps to keep the access attainable for some of our patients, and to keep our local market local, and keeping our services local. And so if we're utilizing telehealth to connect to specialists, they may then refer back to the hospital for ancillary services, for your x-ray, for your lab work, reducing hospital transport costs, in addition to the remote provider in triage, which helps to reduce some of the staffing costs associated with that function. And then also the left without being seen in the emergency department. And we're keeping those patients there for their necessary care and capturing some of that revenue from that visit. In addition, again, it's supporting the workforce to remain in the community. The telehealth can provide that access for your own workforce to remain local. And then there's been some studies that have looked at what is the cost per patient who utilizes telehealth for primary care services versus, the in-person primary care, and what's that direct cost. And you'll see there, it's, a significant difference for 1 year of total cost per patient, telehealth versus, the direct traditional home-based primary care model. And then obviously, as we're in this public health emergency for COVID, any provider that's eligible to bill Medicare can also bill for telehealth services. And we've lessened the restriction on where that patient or that provider is located. So accessing, telehealth remains easier than it has been in years past, and that the ability to bill for it through Medicare has been more attainable for providers who are on the fence perhaps before, are able to now do that now. And hopefully that is something that will continue on after the public health emergency. And then looking at the impact of telehealth on value-based care, we look, towards the triple aim. So reducing the cost for the patient. We keep them local. We, there's limited travel costs that they're needing to leave work for appointments, or they're not obtaining the care that they need promptly. If they were, stuck at home because of a snowstorm, they can still get some of that care if telehealth is something that's utilized. It's convenient and it's affordable way for most to access. And also, affordable for the hospital or the clinic as well. And then the whole chronic disease prevention and management in the way that it's, from remote patient monitoring and keeping those patients on a routine and monitoring their chronic conditions, will hopefully prevent, some of those high risk, high dollar visits to the emergency department when their care is not being properly managed.
So how to get started? The Center for Connected Health Policy notes 10 keys to success. Securing, of course, the hospital needs to secure the support of executive leadership. And one thing that I think, the second bullet there, performing a comprehensive needs assessment, is really one of the most important things. Understanding what your organization needs. Prior to COVID, Lindsay and I had the opportunity to travel around the country and go into our rural hospitals. And many times I would see this really nice telehealth equipment and ask about that and find out that they're not using it. The equipment is not the first thing that we buy. We need to know what the community needs, what do our patients need, what does our organization need, and there's a wonderful organizational wide needs assessment that can be done that can really pick out those specifics. We all want to jump on board, but what do we really need and what's going to be the most important for us? And then dedicating someone to really coordinate those telehealth services. And be the champion and the go-to. Standardizing processes are really important to make everybody feel very comfortable with the services that we're offering. Understanding and appreciating technology, which can be challenging, but we have to take that one step at a time. Having our providers buy in. We used to hear that we would see pushback from providers on telehealth services. But COVID has really changed a lot of their opinions and their attitudes toward using telehealth services. Being selective in contracting, because specialty care services are varied and some offer some opportunities for us that others may not. And then as we are disrupting the situation, anticipate and respond constructively, increasing the role of our mid-levels. That's highly important. And our mid-levels seem to be a little bit more interested in embracing some of the telehealth capabilities and opportunities we have, and then just demystifying what it is. Of course, we can't say that it works for everybody, but generally speaking, the data is showing that during COVID, where there weren't a lot of choices, that we saw that telehealth was embraced and has become a method and methodology that we're probably going to be using in a greater degree than, of course, we were before, which is great. Next. So we welcome any discussion around the presentation or anything that we said, or you want clarification on from Lindsay or I or Nicole, if you want to take it from here about further discussion with others.
Yeah, thank you for that information. Anybody have any questions for Carla or Lindsay from anything they heard in the presentation? There's a question in the chat from Kyle Cameron in Wyoming. She's asking how private payers are accepting telehealth reimbursement.
Thanks, Carla. I think that it's all dependent on its state to state. And then I know that even at the Medicaid level, it's varied state to state on how they are. And yes, it does. Yes. Your comment there around, it does appear that Medicare and Medicaid will continue to reimburse. I'm hopeful that they will increase on the physician fee schedule the amount that they are reimbursing for telehealth services. I'm hopeful for that, but I'm not sure if they will be or not.
Well, and that was one of the reasons that MedPAC felt like we really need to continue with the public health emergency for a couple of years, or what has been allowed through the public health emergency for a couple of years, so we can really gather some empirical data. I mean, without the data, we can't show we can't show that there's been good outcomes with the use of telehealth. You know, and better adherence to medication and care planning regimens and so forth. So at this point, I mean, we know with CMS, a lot of there will need to be legislation. And then within our states usually kind of sit back and wait to see what's going to happen at the national level before they start really pushing things. But you know, right now we haven't heard. I know that our private payer is a commercial insurance, pays for, and they welcome the use of telehealth services, especially for things that are, you know, minor, that are follow up and so forth, so that it's a lot less expensive for them.
Mm-hmm.
And then to respond to your questions about what can the hospitals do to encourage, I think that's a great question around what can hospitals do to encourage the continued increased telehealth reimbursement from private payers and CMS. I think our hospitals, you know, they can go to their commercial payers and renegotiate contracts, and they can bring forth, you know, opportunities for paying for value to these payers. And the payers may have special programs within these contracts that the hospitals should get in touch with them and explore those options. A lot of times hospitals are receiving payment for value, for instance, but have no idea why they're getting this per member per month case management fee. But you know, there are special programs with some of these commercial payers that hospitals and clinics can be taking advantage of.
Great. Any other questions? Thanks for your questions, Kyle. All right, Scott Daniels, are you with us? I asked Scott to be here today. He may have been here anyways, but I had asked Scott to talk to us about the use of telehealth in Hawaii. And the reason I asked Scott is because it's not new by any stretch. It's something that's been going on for quite a while, and Scott has been fairly involved along with partners in his state. So I just wanted Scott to talk a little bit about the experience with it in his state and how it's benefiting the hospitals and clinics there.
Hey, yeah, I'm on. I'm more than happy to talk a little bit about the Hawaii experience. One of the things that when asking about private payers reimbursing, it does vary from state to state, and it'll depend on sort of the regulations within your state, and that we worked several years to get regulations passed in our state, and it took a couple tries. We passed something and we still couldn't get the payers to pay. We now have Hawaii, from what I understand, has one of the more progressive telehealth laws in the country. If you go to the Center for Connected Policy, I think they have a copy of the Hawaii rules there. But the thing is that it was something that was worked on for a long time, and every time it came up, we'd find a new problem. One of the problems that we came across early was that basically the malpractice insurers, they weren't clear on whether they would cover telehealth insurance for malpractice or not. And so the last round said, if you are going to offer malpractice insurance in Hawaii, you have to cover telehealth also. We also have in there that private payers have to pay telehealth at the same rates as that they would if it was an in-person visit for similar services. Things that are, things that I think to keep in line with sort of how it's helped basically with quality and access and all of those issues. Hawaii, as everyone should know, is an island state. So if you want to see a specialist, that means you probably have to go to Honolulu, or you're going to have to go to Oahu. Despite what people think, there are no boats, there are no ferries between the islands. It means you have to get on a plane, you have to fly over to Honolulu, you have to arrange transportation on the other side in order to see your specialist. You may go into your specialist may spend 15 minutes with you and go, okay, that's it. And now you have to get back to the airport, catch a flight, go all the way back. Usually what will happen is, because you're already going to Honolulu, you're going to make it shopping day and everything else. But the thing is, it's not just a couple hours out of your day, it's your whole day to do something like this. So there's a huge advantage to using telehealth, basically to allow people to do, especially for those 15-minute, 5-minute rule out things, in which you can catch them, whether it's store and forward or whether it's synchronous, live, however it's done, that there's a way to basically just sort of rule stuff out. And as telehealth becomes more a standard of care on the financial end, being able to use telehealth to rule things out becomes a standard of care, which helps to prevent the hospital or the provider from being liable for missing something because they didn't use telehealth. And that there was a case I don't know how it turned out, but there was I think it was actually settled, so we don't know what the law in the end would have said on it. But there was a case in New Mexico where there was a provider that was sued because they didn't use telehealth when they had access to it to rule something out, and the person ended up with a bad outcome, and so therefore the provider was sued because they didn't use a standard of care that was available to them in order to rule out. Telehealth isn't just about providing medicine and doing diagnosis over telehealth. It's also useful for ruling things out. And I think people always forget that that's a big part of medicine also. It's just sort of ruling out, do you need to come in? Is this something I need to see? That can be handled quickly, right? You can do, dermatology does a lot of store and forward. Telehealth, store and forward is, I mean, it sounds new, but all of our radiology is done by store and forward now. I mean, it's just, telehealth is not that uncommon. You know, radiology, you take the scans and you send them up you send them out, and then a remote radiologist goes through it and they get back the report. It's all done store and forward. It's all telehealth. We just don't call it telehealth for whatever reason, or telemedicine, or whatever term we're going to be using. But it's all done that way. But you know, one of the things that used to always frustrate me with providers is that I can't do telehealth because how am I supposed to palpitate the liver? And I'm going, what's this thing? It was always palpitating the liver. And I go, what's this thing with palpitating the liver? I don't think I've ever had my liver palpitated at all. But the thing is you don't need hands-on experience, or you don't need a hands-on session basically to rule something out, or to say, this is something that I need to see now. Right. And so basically, if you have a question, you can do that over telehealth and go, oh no, that's something here, you know, that can probably be for a dermatology thing. You know, we'll try a cream, see how it works for a week. And if it still persists, get back, you know, either come in or get back onto the telehealth. Or you can say, oh no, that's something you need to come in now, or you need to get to emergency room.
Come in so I can palpitate your liver, please.
So I can palpitate your liver, right?
Yes.
for that rash. So, and speaking of emergency rooms, one of the things that Hawaii has also is Telestroke. This is a huge benefit in Hawaii because, as most of you know, there are effective medications for dealing with stroke, but it needs to be delivered in a timely manner. And if you have to travel a long distance before anyone can make that assessment on whether you should have that medicine or not, that window may have lapsed. By having a Telestroke program in all the hospitals and all the ERs, basically where they can come up, we have a stroke case. Is this a person that should be getting this medication? That helps save lives and helps improve the quality of lives of people who suffer stroke in rural and remote areas. There's still the issue there. I mean, there's still an issue of trying to get the person from wherever they either have the stroke to the ER in time. But the thing is that you now no longer have to worry about, do you have a neurology specialist on hand that can make the assessment on whether they need this medication? They just go into the Telestroke program, and that they can basically tell you, yes, this is what you do, and take care of it. I can go on with more. I mean, I have lots of stories. I have, but I mean, telehealth it's been something I've been involved with probably about as long as I've been with the Flex program. One of the great resources that if you have not, I'm sure everyone has, but in case you haven't, make contacts with your Telehealth Resource Center. We're fortunate that we have one in Hawaii. It's the Pacific Basin, so they cover Hawaii and Guam, and I mean they cover the Pacific Basin, which is a huge area. But you know, I know the people there. They're good friends of mine, and I've actually worked with them on grants and side by side with them on plenty of things. But please, you know, make contacts and friends, and use your telehealth resource centers to get whatever knowledge that you can. And if you ever have questions, I see someone keeps putting up the thing. So I'm also going to go. If you ever have questions about equipment, there's also a telehealth resource center around equipment, and I can't remember its name at the moment. But Nicole, you can figure that out and put it on.
They
there.
will, yeah.
But they also have road shows. Basically, we've had them out here, and they basically brought out a bunch of different equipment where the providers could come out and try the different telehealth equipment that's available to them in order to do that things. But like I said, you know, it keeps the providers. You know, it limits their liability, because if they use telehealth, it helps keep people in their communities. It helps increase the access to care. I think you get just as good quality or maintain high quality because you can rule out on whether someone comes in or not, because there are things that can be determined on telehealth that, do you need to come in or not? Is this something that needs to be handled right away? And in terms of value of care, absolutely. It's just, again, being able to do that quick rule out, you know, it's just better for everyone. The doctor doesn't have to spend a lot of time worrying about, we have this person on my schedule that I need to, you know, I don't know how many times you go into, you know, you make an appointment in a doctor's office, unless it's the first thing in the morning. By the time they get to you, everything else is dragged on, and a lot of those probably could have been handled fairly quickly. And then there's a couple that probably couldn't. If you can offload some of that stuff onto telehealth, yep, and have maybe a nurse practitioner or a physician assistant handling a lot of that stuff, and then the doctor handling the stuff that come in, see me type of stuff. That helps improve the efficiency of the office and of the entire system, and it helps improve basically everyone's day in terms of going to the doctor on that day. And then, like I said, it gives everyone access to specialists. So, and then Carla had mentioned Echo, and I just wanted to reiterate, Echo, we consider Echo as a part of our telehealth program in Hawaii. It is a way to basically, again, take off some of the pressure from the specialist, because now if you do open up telehealth, now you have very few specialists seeing people from all over the state. But the way is, if the specialist can train primary care providers in the things that they can do and that they are allowed to do, that it's basically increasing their confidence so that they can handle that endocrinology problem or the mental health issue or well, I'll use geriatric since we have a geriatric issue. We have a child trauma echo in Hawaii, and we're trying to get a EMS echo up and running in Hawaii. But the thing is that the point is, it's trying to get your primary care doctor who's already certified to do a certain level of medicine, basically the confidence and the knowledge in order to do the stuff to basically ease the burden on the specialists also. So again, you're trying to, using telehealth basically to try and tier people to go to the proper thing. So it frees up the entire system to more appropriately use the resources that are available to them. And I've talked long enough and I'll stop.
Thank you, Scott. I see Terry turned his camera on, so I'm guessing he has something he wants to add to what you're saying, but it struck me as you were talking, we're discussing earlier in the presentation about if you're considering telehealth, think about this. So many hospitals are trying to decide if it's something they can, should, want to take up and that sort of thing. But the way you describe just the geography of Hawaii just makes it a necessity. It makes it something that hospitals don't even need to think about or wonder if it's what they should do. It's just so much better for everybody. And it's not only better and makes people happier because they don't have to get on a flight and get there and spend their whole day doing that, but just flat out absolutely saves people's lives when it comes down to it. Like, this person might have not lived if they hadn't had access to that Telestroke or whatever it was. So that's kind of what struck me as you were talking. We're considering options here, but it really is just necessary in a place like Hawaii. That's all islands. And how do you get around?
Well, and Nicole, I would also like to add to that too, that we have seen a great benefit of telepsych in the EDs, because, your ED providers don't want to send someone home that they're really not comfortable, that they are safe to go and go for outpatient. So unfortunately, a lot of these patients who really don't need to be placed sit in our EDs and board, waiting for placement, where they go and they say, you really didn't need to be here. Mm-hmm. And then they send them home. So using telepsych really gives everybody a better feel for what can be handled outpatient wise, get everything straightened out for them in a good plan as they're released to home with a follow-up plan. And it makes the ED providers much more comfortable, and it provides a much better outcome for that patient that, we all have a trouble placing people anyway. Mm-hmm. And when they don't need to be placed, that's a great advantage.
Yeah. We also have, Terry, I'll give you a second, I promise. We also have Renee Clark from North Carolina to talk about that exact thing. But Terry, before we ask Renee to talk, did you want to add something to? Okay, Renee, you've got some weird sound coming. Go ahead, Terry.
Just a quick comment. First of all, I really appreciate Scott's comment about ruling things out. I haven't heard much of that either, Scott. And that is just a huge advantage because, again, it's not just Hawaii. We have rural Minnesota where if you live in some of the fringe areas, you got to come 250 miles, and it's not as expensive as flying, but it's still extremely inconvenient. And for a lot of people, they just don't have that access. The thing I wanted to mention, which is being evaluated and has really very impressive outcomes, is hospital at home. In other words, besides all these other things we're talking about, we are talking about Geisinger, Mayo Clinic, and some of these other big systems that are basically saying we can do a significant amount of acute care. We usually do in the hospital, or we do an outpatient basis right in your home. And as there's a number of these big systems that are actually doing this. And when you look at the outcomes that one of the reports they have is just in terms of the outcomes, it's saving 30-some%, it's higher quality, it's higher patient satisfaction, et cetera. And that leads many of the folks that are supposedly know something about this to predict that most of our care, and in fact, the American College of Healthcare Executives held a recent session, and I don't know if I buy this because it is so extreme, but Dr. Joe Burrows, who made this particular presentation a couple of weeks ago, said 80% of our healthcare is going to be provided virtually. Now, whether you think at that extreme or not, I'm absolutely convinced that a significant percentage is going to go that way. And it is extremely important that our rural hospitals and our rural clinics be prepared for that. And they kind of make an informed decision about where they are going to fit in this new telehealth world.
That is a crazy number to think about. I know we were just talking about that in task team meeting earlier this week, and that just blows my mind.
I know.
All right, Renee, let's try you again. There you go.
Can you hear me now? Does that sound better?
Yes.
Okay. I'll be real brief. It looks like you guys have already covered so many things. Speaking of telehealth in the emergency departments, so I'm here to talk about the North Carolina State Telepsychiatry Program. So North Carolina, although doesn't have any telehealth policies on record like Hawaii does, the state did fund the state telepsychiatry program. So in 2013, the General Assembly actually told the Office of Rural Health that you will be running $1.82 million at that time, $1.8 million through your office now to run this program through East Carolina University. So I think most people just want to hear the real brief numbers when it comes to the financials that the program has saved. So as of December 2020, this year, so they were inception in November of 2013. So we've been roughly now, we're going on year 9. There are 41 hospitals in network throughout the state. The way the telepsychiatry program was set up is that it began in hospitals, rural hospitals, and that's where the predominantly it is right now, but the push will be, like Terry just mentioned, we're going to value-based care, probably preventative and going towards community-based sites. But at this point, we're at 41 hospitals currently. So the big numbers, total encounters since this program has been started is 33,173 total assessments in the emergency departments in North Carolina. And then like Carla was mentioning, the number of involuntary commitments is the way that this program calculates savings. So the number of IVCs, involuntary commitments total, have been 6,408 throughout the program. So that means, unfortunately, I mean, let's say this last quarter was broken down, there were 783 patients that went into the ED with an IVC. Then 39% of those were overturned just this quarter. So they calculate the savings showing, the throughput, the savings to the hospital, the savings to the community, the law enforcement as $34,603,200 since program inception. And I would like to point out that the program often even states, this is just really specific to involuntary commitments overturned. So, I mean, we could talk about, I'm sure, the millions and millions of dollars that are being saved in preventative cost of just time, of burnout of people that don't have to deal with these patients anymore as longer, the law enforcement, travel. I can't even imagine just all the savings that could be calculated that we just can't calculate. So I wanted to keep it short and brief. I guess the biggest point is that right now it's in 7 of our critical access hospitals have Model 1, which means, I guess I should really explain what it is, but basically I assumed everyone knew what a telepsych consultation would be, was that if the patient comes in with an involuntary commitment or a mental health emergency, that hospital can then log into a portal that to ECU and their hub providers, and then they would give the patient a psychiatric evaluation. The hospital ED provider will, of course, then make the ultimate decision. So that's another thing that takes time and it hasn't been calculated, is the relationship that ECU has built over time throughout the entire state of North Carolina for these ED providers and hospital staff to feel comfortable actually overturning an IVC. I wanted to keep it brief because I know that I had very limited time. So does that give a good breakdown?
Yeah, I think so. Those dollars are amazing. And like you said, you're only talking about one aspect basically of the savings that are happening. And I mean, really just the stress on the emergency departments, having people there for so long, most of the time, to be able to just address it and keep it moving, that is amazing too. Carrie, did you have anything you wanted to add to what she had to say? You're on mute.
Yeah, absolutely. And this all fits into our value-based ACOs and global budgets as well, because this ability to reduce costs substantially, and you know, I'm not sure how long we can sustain, you know, equal payment for telehealth services, because, you know, in essence, the government's going to want to reduce some of their Medicare costs and et cetera. So, you know, we'll arrive at something that needs to be fair in terms of reimbursing our providers as well. But telepsych, when you look at the cost of diabetes, for example, and then you look at the cost of diabetes with any sort of mental illness or behavioral health, it's sometimes 3 to 4 times as expensive. So when we take telepsych and we're treating a patient, you know, who may have a chronic illness, we have this real potential of managing that behavioral health emergency and therefore kind of reducing that overall cost. So, I mean, the very cost savings and now the evidence that this can be safe and the patients might like it, and even the physicians seem to be getting on board, really, I think means that we are going to see telehealth everywhere. And it's one of the solutions. You know, I live 20 miles north of Duluth, and I'd love to have virtual visits rather than get in my car and drive all the way down to the urgent care, or if you're a mother and you've got kids constantly. So I just think it's a great solution for rural America. And we don't want it to sink our hospitals out there, so they need to get ready for it.
So we're almost out of time here. I guess the one thing I want to say is this webinar really was focused on finance, quality, and value-based care. And Carla and Lindsay did talk about the market threat aspect, and that's something that we've been talking a lot about at TASC and the center, and I'm sure you all have some thoughts about that or having some conversations about that. We just had an HIT coalition meeting earlier in the week where we had a whole presentation about disruptors and market threat, and it was actually very detailed, talking about not only Amazon, but also Apple, and not only CVS, but Google, Microsoft, what all of them are kind of working on and what their roles are. So I would say if you missed that webinar, when the recording comes out, it'll hit your inbox here in a few days. Check that out. It really is something to keep on our minds, this idea of market threat for rural hospitals with the big telehealth boom and these big players that are jumping into that game.
Nicole, just one more thing on that is the TASC is going to be preparing a manual that could be useful for our flex programs, and also something that might be relevant to our critical access hospitals. So we expect to have that out and produced by the end of this program year.
Which is the end of August for us.
Yep.
Yeah, so more to come about that. Well, thank you so much, Carla and Lindsay from Stroudwater. Thank you so much, Scott and Renee, for being here at the end of your day on a Friday. Actually, Scott's probably still like late morning or something, but I really appreciate you guys taking the time to come and talk about the initiatives in your state as well. Thank you so much for that. Andy just popped up some polling questions there. So the two you answered earlier that were gauging your knowledge before the information was presented, the same two questions again, plus a couple more. If you would just take a quick minute or two to answer those questions, I would certainly appreciate it. And after that, we are done. So answer those questions really quick and then have an awesome afternoon and have a good weekend. Thanks, everybody.